Thanks very much, Larissa. And now we're going to hear two respondents to these talks. The first will be Kathy Alfonso from the American Cancer Society.
Thank you. And thanks to the conference organizers for allowing me to be here and respond to these great talks that we just heard. So my response is going to be in the form of a blueprint for what we need to do in the next decade for cancer survivorship. But first, I think as Larissa just pointed out, thank you, Larissa, we have made incredible progress in the last decade. We have made progress in every single one of those 10 recommendations from the Lost in Transitions report. We have built that bridge from the ground up. And I think this is thanks to the really dream team, as Patty said, of leaders who are in this room. Special call out to Julia Rowland, who, like Neeraj, mentored me. And also one leader who's not in the room, and that's Ellen Stovall. And I want to bring her here with us. But that bridge is half built, right? This is what Neeraj was just talking about. We're still loading, we're still working, we're still buffering, right? We have a lot more work to do. And what does that mean, we're still loading? Well, it means right now in the US, we have a variety of factors that are conspiring to produce what I call a perfect storm in our inability to care for people with cancer. Right, first of all, it's the numbers. We have that 15.5 million survivors, another nearly 1.7 million that are diagnosed every year. We know from all of the great survivorship science that's been done that survivorship is associated with all kinds of morbidity, the chronic and late effects of cancer, the physical problems, psychosocial, the functional impairments, the financial toxicity that we've been talking more and more about, especially in the last 5 years, that really affects people's ability to work. All of these problems, these are all bins of talks that we're going to be hearing in the next day and a half. And we're bickering a little bit about who should really provide ongoing care for cancer survivors. But really, we're facing provider shortages in oncology, in primary care, and nursing, so none of us can do it alone. And we know we have provider knowledge deficits, especially in our primary care workforce, who doesn't get any information about caring for long-term and late effects of cancer in their training. And even some oncologists who don't know how to manage all the long-term and late effects, especially the psychosocial ones and things like sexual functioning. And then to top all of that off, we have skyrocketing costs of cancer care, but also of the excess medical costs of being associated with being a survivor. Right, those management of all of those comorbidities that Neeraj spoke about, and that ongoing care that people need. So the only way to weather this perfect storm, the only way out of it, is really to use what I'm calling a blueprint of strategies for the next decade that will change the mindset about what survivorship is and when it starts, change the model for care delivery, and change the language that we use to talk about cancer survivorship that honors the diversity of patient trajectories. I'm going to talk about each one of these in turn. So first, change the mindset. When I say cancer survivorship, pretty much all of your heads just went to, oh, she's talking about long-term survivors post-treatment. And that's because we've spent an incredible amount of effort trying to understand the landscape of what are the issues that are faced by long-term survivors. And that's been incredibly important work because we had to understand that, and that had never been done before. And we have to keep doing that because the long-term experiences of cancer survivorship of survivors treated today, 10 years from now, are going to look very different than the things that you're hearing about from Neeraj and others who were treated years ago. So we have to continue to do that work. But at the same time, we've learned from survivorship science that if we're going to have a lasting impact on really creating long-term well survivors, our interventions have to be delivered much earlier. Survivorship has to begin at diagnosis. We have to orient both providers and patients to thinking about creating well survivors and thinking about that long-term from the very beginning. And that involves the second goal, which is change the model of care delivery. So it's not good enough to just not manage toxicities until something called post-treatment survivorship care, right? We have to, in the United States, implement a system for screening for toxicities and managing them that happens from the moment of diagnosis forward. The goal should be preventing toxicities where we can, and more science is coming on board every day that will help us do that. Where we can't prevent these problems, we need to identify them early when they're small, when they're treatable, and when they haven't caused for other problems that are limiting this patient's functionality. And even if we can't treat them, we need to intervene to prevent disability from them. This is going to involve expanding the team of providers far beyond oncology. We need to always be including the primary care provider, but we also need to help oncology developing algorithms to help our oncologists refer to a multidisciplinary team of providers, for example, from cancer rehabilitation or psychosocial care, palliative care, and other kinds of providers like advanced practice providers, nurse and lay navigators, I think are going to go a long way in helping with the workforce shortage issues. And maybe some online tools, some virtual tools like an Alexa for Cancer who can help us with some of the surveillance that we need to do. Care has to change to focus not just on treating today's problems, but also on preventing recurrences, second cancers, but also preventing those late effects. It's the only way to get that economic well-being that we're looking for. And then finally, as people are transitioning out of primary chemotherapy and radiotherapy into follow-up care, we need to recognize that one size does not fit all. Patients don't have the same kinds of issues that they're dealing with. And so we have to implement in this country risk-stratified follow-up care, like they do in the United Kingdom, where the number of providers and the kind of providers that you see and the intensity of the interventions that you get varies with the need of that patient. In the US, we've been talking about risk-stratified follow-up care for the entirety of the last decade. The most recent paper on this was Larissa Neklourov's, who talked about, there could really be 3 different kinds of risk strata. So we might have really high-risk patients. So these are patients at high risk of not just disease recurrence, but also of morbidity, of late effects, of comorbid conditions that need to be managed. And so they've got to get stratified to a multidisciplinary team of providers who has a lot of oncology expertise, maybe followed in oncology in perpetuity. On the other side, we've got patients who are pretty low risk. They're low risk of their disease recurrence, of sort of average risk of second cancers, low risk of cancer morbidity, and they can probably be followed by their primary care provider, even if their primary care provider doesn't know all that much about cancer. And then there's an intermediate risk group too. And what kind of care they get and who delivers that care is going to be some of the work that must be done in the coming decade. Part of changing the model of care delivery is going to involve capitalizing on the precision medicine movement right now and using a precision medicine lens to create right-sized care for a given patient. What do I mean by that? I mean, we have to be able to capitalize and leverage all of the diverse kinds of data that are coming online right now to understand the risk of what puts someone at risk for long-term and late effects, and also the mechanisms by which they have that risk, and that risk exists. So it's not just genomics, right? It's also, what is that person's psychosocial history? Do they have a history of depression? What are their health behaviors? What kind of exercise and diet do they get? Do they smoke? What kind of environment are they living in? Do they have support in the house? What kind of resources do they have? Right, integrating, what other kinds of labs can we get? Comorbid conditions are these people dealing with? How do we integrate across all of those kinds of data to understand risk? That's using a precision medicine lens. And then we know that we can't move policy in this country unless we make the business case that this new model of care matters, that this new model of care is the right one. And that involves collecting outcomes that show that if we intervene earlier, if we prevent toxicities, or if we better manage them, that we've got better patient functioning and quality of life, absolutely, and the preserved ability to work or re-enter the workforce or care for aging parents or whatever life roles are. That we improve clinic flow, that we free up oncologists to deal with all of the people who need their primary chemotherapy and radiotherapy rather than following people who, as Neeraj said, for, 13 years until you said, we probably don't need to see each other anymore with your oncologist. So that we deal with the workforce shortage, we need to measure that. And then that also that this system results in changes and improvements in healthcare utilization and in healthcare costs down the road when, for example, patients aren't presenting to the emergency department to manage toxicities because we're better managing them up front. Third, we've got to change the language that we use. So the word survivorship has been a part of my job title for a long time now. And I can tell you I have heard the gamut of people who love that word or hate that word and all of the reasons why they hate that word. I think we have to think about our language and how our language reflects on the diversity of patient experiences that we have. We have patients who are post-treatment and cancer-free. But we also have patients who have cancer, but they're on active surveillance. They're not requiring treatment right now. And they have to live with that every day, that knowledge that they have cancer, but they're not getting treated yet. We have patients who are dealing with sort of relapsing, remitting disease, right? Where sometimes they're intermittently they're on treatment and then sometimes they're not. And then we also have patients who are living with a chronic sort of metastatic disease, right? We need language that's inclusive of all of these people, and we need language that honors people who want to fight the war and people for whom that metaphor does not work and they hate it. So do we need a different word, different phrase? I don't know, and I don't know what it would be. But as we go forth into the next day and a half and into the next decade, I want us to be thinking about our language, because we can't afford to leave anybody out. And finally, we must accelerate progress, like Neeraj was saying. So when I talked to Matthew Zachary, who's the founder and CEO of Stupid Cancer and an AYA survivor, about this meeting, he said, oh, that IOM report in cancer years, that was commissioned around the time Lincoln was assassinated. What he meant by that was that cancer is changing so fast, and we've got to change that fast with it. As Neeraj said, today's survivors and tomorrow's survivors are counting on us to be able to provide quality care, even in the midst of this crisis. We have got to capitalize on existing efforts in order to do that. And one is the precision medicine effort, and two is the cancer moonshot in order to make that happen. And the American Cancer Society is going to be partnering with many of you in that room on 3 national efforts to really step up and take the next concrete steps in many of these things in the fall. One of those efforts is on cancer navigation, one is on building out risk-stratified care approaches, and a third is on better managing and mitigating its toxicities. And you will be hearing a lot more from us as the fall goes. Thank you.